All right, so here we are today with Charlie Resnikoff, our most prolific speaker of all time. He has been spoken on Echo, our Echo, more than any other speaker in the world. And so he's talking today about what some new topics in addiction medicine. And so welcome, Charlie.
So I just wanted to make sure that we got word out. I know that everyone received an email from Katie as well, but we do have a boot camp coming up on May 7th that is geared towards jail administration, sheriffs and correctional leadership, as well as jail medical. So if any of you are working tightly with your local correctional facilities, please share this with them, as there will be a lot of good content on how to start thinking about and move into implementation of a mood program within the jail.
All right, remember we got some good upcoming talks. The human trafficking talk, again, that's part 2 from Kate LePage, and we have Claire Drom, who's actually from Centricare, to begin doing a talk that I saw not too long ago. It's a fabulous talk. And then ADHD treatment in patients with substance use disorder, a thing that comes up almost every week in our clinic. So lots of fun things coming up. And actually, we have some other speakers have already said they're coming back as well, some of the favorites. So we have a few that aren't up here.
There is free CME for these sessions, and just keep in mind that we love to see all your faces. So please turn your camera on if you're able, and make sure you fill out the stuff that Katie sends following the session to claim your CME.
Yeah, keep in mind, Charlie's going to be giving this talk to hundreds, if not 1,000 people coming up. So it would be really helpful if everybody's face was on here so that he gets that feeling, like what it's going to be like. So go ahead, next slide. So again, if you need us for anything, please just give us a call. I think everybody's got our phone numbers, so please call us at any point.
Stratus Health is the home to the core website, so don't try and reinvent the wheel. Check this out first if you're looking for any policies, protocols, anything like that. Hopefully we can make life a little easier for you with some of the resources on this page.
All right, and with that, we'll let Charlie share his screen if he would like to do that, and we will let him introduce himself, although I think most of us know him already as people continue to connect, Charlie. So, give a long introduction for yourself to let people connect more.
Okay, or just dive in, and people, I mean, it's cases and whatnot. So if people get in a little late, no big deal. And I'm really excited to get to share this with you. And yeah, definitely ask questions or heckle me. I gave a talk at this conference 2 years ago, and I do not get nervous that much, but the room was like so big that I actually I was like, that was as nervous as I've ever been presenting since way back in my younger days when I hadn't presented. The host needs to let me screen share.
Sorry, I was going to ask you, do you want to share yours?
Either way, whatever you rather.
Yeah, you can go ahead if you want.
Okay.
Then I have your polls.
Oh wait, you set up my polling. If you set up my polling, you should share, because the polling thing doesn't work on my end.
Well, I have them in Zoom.
I don't know what that means.
Yeah, okay. I don't know what that means
You
either.
just go ahead. If you want to share your slides and do it, I'll handle the polls when we get to it.
Oh, got it. Now I know what that means.
Don't question Katie.
Okay, can you all see my screen?
You need to make it a little bigger. There we go.
Okay. All right. So yeah, I was asked to kind of come up with what I thought were like new, they have to be like evidence-based, like established, not like fringy, but like new things that internists or people working in primary care, but it's mostly for internal medicine, really ought to know in 2024. So I am just getting paged. Oh, Brian Gran just totally
Just say,
Okay.
just say, Brian, I'm okay.
Brian, thanks, Brian. Okay, so cannabis use in the aging population, preoperative assessment for those who drink alcohol, successfully treating opioid use disorder with buprenorphine. And that's one which we might need to modify for this audience because y'all are like pros. And caring for methamphetamine use disorder. So those are sort of like the 2024 update on each of those. And I am very excited most of all about the cannabis one. And we'll start with a case. And the case goes like this: 72-year-old man with insomnia, coronary artery disease, atrial fibrillation, hypertension presents to the clinic. Your average 72-year-old. He smokes cannabis. He smokes a cannabis joint prior to bed as a sleep aid. He does not drink alcohol or use any other drugs. He has no prior history of substance use disorder or psychiatric diagnosis. His medications are amitriptyline, apixaban, a blood thinner, aspirin, atorvastatin, lisinopril, and metoprolol. So just like pretty standard treatment for all his medical problems. His blood pressure is okay. His heart rate's a little bit elevated, 92, and his exam is basically normal other than an irregular heartbeat. So the question is, which one of the following is not a concern with this 72-year-old with heart disease, etc.? So now is where the magic of Katie happens.
And you all,
Katie,
there we go. This is the first time we've done polling with this new iEcho, so it's just a teeny bit different. So
okay. So whenever, are you in charge of when to end it, Katie?
yeah, I wait for just a few more people.
Okay, cool. Okay. Okay, yeah, you guys are all over the map. Awesome. That's why we're doing this. So, drug, I'm going to talk about all these things. Drug-drug interaction is a big deal, but it's a big deal with CBD, less so with THC. The rest of them are concerns for this patient. So here's the deal. We had this idea about what cannabis does. Cannabis doesn't kill people. Cannabis doesn't cause heart attacks. Cannabis doesn't cause cancer. These are things that I used to teach these. We really believe these. But part of that reason we said all that is because who used cannabis? Young people. 85% of cannabis users were people in their teenage or 20s. But now you got the baby boomers retiring. They've got a little disposable income, and marijuana is legal. And they used to smoke, they used to smoke marijuana when they were in college, and now they have disposable income and it's legal again. So now you've got older people returning to cannabis use. This is a phenomenon we're seeing now, and it's increasing. This is the best recent data I have, but it increases. One of these other studies is more recent. Up in like the rates of older people using cannabis is rising and rising and rising because of a variety of circumstances. And we just have no idea. We know what happens when a 20-year-old uses marijuana. We don't really know what happens when a 70-year-old with other medical problems uses marijuana. So that's what this is about. But I wanted to just I wanted to read Peter Tosh's Legalize It, some lyrics from this. It's a reggae song. You should definitely check it out if you haven't already. Peter Tosh says, doctors smoke it, nurses smoke it, judges smoke it, even lawyers too. So you've got to legalize it. Don't criticize it. Legalize it, and I will advertise it. It's good for the flu. It's good for asthma. It's good for tuberculosis, even Umara composis. And so you might ask, what the heck is Umara composis? It's like an old-timey way of saying menstrual pain. So I thought this was like an amazing lyric to write in 1976. First of all, that doctors and nurses smoke marijuana, but also that he's saying he lives in Jamaica and he's saying marijuana is good for tuberculosis. I thought that was interesting. But so what does cannabis do? This is not a comprehensive list, but this is kind of my list of the benefits and harms of cannabis. And I just think you can't overlook pleasure. The reason almost everybody uses cannabis is because they enjoy it, and that's okay. And I think that should be truly part of the benefits of cannabis. We shouldn't overlook that because that's why most people use cannabis. People do use cannabis for sleep. People use cannabis for nausea, chronic pain, muscle spasms, and to suppress nightmares, which is kind of related to sleep. I think all of those are very valid benefits. Harms, I'm going to talk about cardiovascular harms, falls and car crashes, cannabis addiction, I won't talk about a ton, but learning and memory issues, I won't talk about a ton either, but you can imagine those would be relevant for the young and the old. Mental health issues, cannabis hyperemesis syndrome, I'll talk about that, and cannabis withdrawal. And cannabis withdrawal, a lot of people who work in the hospital setting see people who use cannabis come to the hospital and then go into cannabis withdrawal when they're hospitalized. So, but the big topic here and the headline news is cardiovascular risk of cannabis, which we had never really understood or accepted until just the last couple of years. And now there is a bunch of new publications showing this risk in the lab and in human beings. So the first 5 things all come from THC, and it doesn't matter if you smoke it or eat it or vape it or how you ingest it, it's the drug THC that does these things. It gives you an adrenaline surge. When you use cannabis, your adrenaline is higher. Number 2, it constricts the blood vessels feeding your heart. It's a coronary vasoconstrictor. If you're 20, who cares? If you're 70, that's a problem. It's a peripheral vasodilator. So we know that because you see people have their bloodshot eyes, but it's not just the blood vessels of the whites of your eyes that get dilated. It's blood vessels throughout your body, in your skin and in your periphery is what, I would call it. So it's akin to being in a hot bath where like all the blood pools and your skin is warm. So the blood vessels of your skin kind of dilate and all the blood pools in your skin. And then when you stand up, you get dizzy. So those effects that I just listed all cause dizziness, orthostasis, and tachycardia. It's really common that people using cannabis when they're at rest have a racing heart and high blood pressure. And then when they stand up, the blood pressure drops and they get dizzy. All of this puts stress on the heart. So that's all THC. But then if you smoke it, you can have inflammation of the coronary blood vessels, endothelial inflammation, and blood clots. And so the smoking kind of adds inflammation and blood clotting, and that's the bottom 2. And so in human beings, a huge thing is atrial fibrillation control. People with atrial fibrillation have worse control if they're heavy cannabis users because the heart is driven to beat faster anyways on top of the atrial fibrillation. The second thing, and I'll get to this later, is previous research said that cannabis use did not cause heart attacks. That has now been refuted, so I'll get to that later. But the first step in refuting that idea is the observation that people who use cannabis on their way into surgery, which might sound crazy, but people do it all the time. They use cannabis as like the last thing they do before they go show up at the preoperative, to prepare for their surgery. And if they use cannabis before surgery, they're 5 times as likely to have a heart problem immediately following the surgery. So then people started saying, like, wait, what the heck's going on? Why would cannabis give you cardiovascular events if you use cannabis during or before a surgery? So that prompted more thinking and research about cannabis cardiovascular disease. And finally, this is an old but good study, and that is if you have like angina or heart failure, and let's say you can only walk 100 yards. If you normally, at your best, you can walk 100 yards and then you get short of breath, or you have chest pain, or you have cramps in your legs, or whatever vascular disease symptom you have. If you then smoke marijuana, or, and these studies were smoking, but I suspect it would be smoking or eating. If you smoke marijuana and then see how many yards you can walk, you used to be able to walk 100 yards. Now you can only walk 50 yards and you'll get short of breath and chest pain and can't. But if you don't, but then if you stop smoking marijuana, and you walk again, you can walk up to 100 yards. So smoking marijuana decreases your exertional capacity by 50. And that's significant for people who are older with cardiovascular disease and heart failure and angina and all the rest. But this is the headline news, and this is 1 month ago in the Journal of American Heart Association. This was published, and this is, I think it's kind of a big deal. This is the biggest and best study of cannabis and heart disease and strokes. And what they found, looking at 400,000 patients, 4% of them were daily cannabis users. So 4% of older people, these are older people, 4% of adults and older people use cannabis daily, and 7% use cannabis, but not every day. So they have a lot of people they looked at. The more cannabis you used, the more likely you are to have heart disease, heart attacks, a stroke, or a composite, which means all of the above. And this is true whether you use tobacco or not, and this is true regardless of your gender. And these are significant findings. Maybe one of these didn't reach statistical significance for some of the outcomes, but that's even just that is at the very bottom, very close to significance. And the effect size is about a 20 to 30% increase. And actually C, which is stroke, reached a 40% increased risk. So if you use cannabis, you are 20 to 40% more likely to have heart attack, heart disease, and stroke. And I think most of us wouldn't want to have a 40% increase in stroke risk. So I think this is really important information for our patients. On the other hand, just to compare it, what does tobacco do to these same numbers? So if it's 20 to 40% for cannabis, it's 200 to 400% for tobacco. Tobacco is 10 times more powerful, causing vascular disease than cannabis. Nonetheless, cannabis is a risk factor. And so I think this is like an important thing for us to understand, counseling our patients and talking to them. But before I go on to the next slide, I'll just say, I think the other thing that's really unique about cannabis, so you could have heart attacks and strokes, that's kind of like tobacco, but it makes your atrial fibrillation worse. That's kind of like alcohol. So it does make these arrhythmias worse, like alcohol does, but it also gives you heart attacks and strokes like tobacco, but not as bad as tobacco. So it's important to understand cannabis's role in heart disease. So now I'm going to move on to the other cannabis topics I brought up, which is drug interactions. The big drug interaction is CBD, and there's a lot of them. On Monday of this week, I had a longtime Suboxone patient get diagnosed with Parkinson's disorder or Parkinson's disease, unfortunately. And he was put on Sinemet, which is a treatment, levodopa, carbidopa for Parkinson's disease. And he was like, I cannot tolerate that medicine. I just take a tiny bit and I feel terrible side effects. And I was talking to him for a while. Turns out he was also taking a bunch of CBD. And I was like, whoa, CBD interacts with a ton of drugs. And we looked it up. And I think his Sinemet side effects were coming from a drug interaction with CBD. So to be determined, TBD on the CBD, but we'll see about that. So moral of the story, and I tell patients, I think it's very helpful to tell them this, the grapefruit rule. You know how many patients get told, hey, this medicine interacts with grapefruit. Don't drink grapefruit juice if you're on this medicine. If that's true, you should also not take CBD on that medicine because they're going to interact similarly. So, and he was told not to drink grapefruit juice on Sinemet as well. So with THC, there just aren't a ton of drug interactions, but anything with THC that causes dizziness or sedation or clumsiness, yeah, I would say those are risks. Okay, I'm getting the page to get. Let me see. Hey, I'm going to make him wait. I told him I was talking. Okay, so sleep. In the last couple of years, we've really seen a lot more information that people use cannabis for sleep. And indeed, cannabis does improve going to sleep and staying asleep. And cannabis suppresses nightmares. So people with PTSD really like taking cannabis if they have nightmares. On the other hand, in general, it's healthy to dream. And part of the theory of why cannabis might cause people to become psychotic is because it disrupts REM sleep. It disrupts dreaming. It is not healthy to suppress dreams. While cannabis does help people get to sleep and stay to sleep, the quality of the sleep is suspect. And once you take cannabis to sleep, if you ever stop that, you get wicked rebound insomnia. So it's an imperfect sleep aid, let me put it that way. Cannabis, it's surprisingly little has been studied about older people with falls who use cannabis. But there's very good reason to believe that if you're an older person using cannabis, you're more likely to fall. Inhaled cannabis is going to cause this impairment probably 4 hours, edible cannabis probably 6 hours, and motor vehicle crashes. An accepted risk is a 40% increase in motor vehicle crashes if you're driving on cannabis. I think that's pretty fairly well established. Again, that's way less than alcohol, but it is a real risk. So there's a 40% increase of crashes on cannabis. Mixing with alcohol is very dangerous. And we've heard on this echo about roadside saliva testing. I appreciated that information. And finally, there's occupational health studies that show cannabis is associated with workplace accidents. And then I'll do this, and then we'll have one more question and move on to the next topic: cannabis hyperemesis syndrome. I'm sure you've heard of this and seen it. These are episodic presentations in heavy cannabis users, and they are sick. I mean, they have abdominal pain, nausea, they're throwing up, they're dehydrated, they go to the emergency room, the whole 9 yards. They're not comfortable. And they're pretty sick. Symptom relief, they'll sometimes tell you that if they take a hot shower or a bath, it feels better. As somebody douses their head in hot water. You're supposed to tell them to be abstinent from cannabis. I don't know if I've ever had a patient successfully quit cannabis. They just keep using cannabis and deal with these episodes. So instead, what I do once we've tried the abstinence route is I put them on sort of a cocktail of medications, and it's like a migraine. As soon as you feel it coming on, before it makes you sick, just hit it hard with every medication. And you could sometimes prevent an episode. And I've had a number of patients be successful with a regimen of meds, and they stay out of the emergency room and they stay comfortable, but they got to get right on it. As soon as they start feeling sick, they got to really take all these meds to suppress it. And the metoclopramide was the one that helped my successful patient on this. Okay, so we got one more case, and then we'll move on to the next topic. A 63-year-old female presents to the clinic with mid-epigastric pain, nausea, and vomiting. The symptoms began earlier today. She is unable to eat or drink. She has a history of multiple sclerosis and tobacco use. She recently switched from smoking cannabis to edible cannabis to medicate her symptoms of MS. She is on atorvastatin. Diroximel fumarate is a multiple sclerosis medication. It's kind of a new one, and she eats THC gummies. Her heart rate is 105. Her blood pressure is up. Otherwise, her exam is pretty normal. She looks uncomfortable, but her exam is normal. So what is the next step with this 63-year-old who comes to you in clinic and she's throwing up and uncomfortable? Get an MRI because she might have a new MS lesion. Obtain a urine toxicology because her cannabis might be adulterated with something. Counsel her that she has cannabis hyperemesis and tell her to be abstinent or give her medications. Get an EKG or check for the P450 drug-drug interactions. What do you think you would do for her? And I'm going to now answer my pages. Okay, whenever you're ready, Katie.
People are going for the 450, Charlie.
Yeah, so remember, the drug interactions are CBD. That's the big one. THC doesn't cause as many drug interactions. So if she told you she was on CBD, you definitely look it up. I mean, I would just say, going back a slide, 63-year-old presents with mid-epigastric pain, nausea, and vomiting. Stop right there. You got to get an EKG, right? You don't have to hear anything else. So why did the multiple sclerosis and the tobacco distract you from, you got a 63-year-old, women present with more nausea with heart attacks than men. So she needs an EKG. I saw this patient in January, and if you look over on V5 and V6 on the right, she was having a legit ST elevation myocardial infarction, a true heart attack. She went to the cath lab. She has this lesion pointed out with the where it cuts off where the red arrow points, and then on the right is after the intervention. She was having a legit heart attack. Now, maybe, I'm not saying the cannabis caused it or not, but she switched from smoking to edibles, and within a week she had a heart attack. So either that's a coincidence or the cannabis tipped her over the limit. But like maybe she had a higher dose edibles. But the point is, you got to keep in mind heart disease with older cannabis users, and certainly don't get distracted by cannabis hyperemesis, because that is a diagnosis of exclusion. So anyways, that's my cannabis portion. I'm going to power on to the next thing, which is buprenorphine. And you guys are actually really proficient on this. There's kind of like one or two kind of easy things that I think you'll get. A 25, but this one's tough. I will say this case is tough. A 25-year-old with severe opioid use disorder presents to clinic with looking for help stopping fentanyl use. The patient uses no other drugs or medications. They have symptomatic PTSD from an adverse childhood event. They have mild anxiety and chills, but no pain, no diarrhea, and no nausea. Heart rate's 105. The patient is oriented to place and time and is not sedated. They yawn twice and frequently shift about their seat during the visit. They're not diaphoretic. They have 4 millimeter pupils, which let's just call that normal. And they have neither tremor nor piloerection, which is like goose flesh, whatever. So what are you going to do for this patient who's seeing you in clinic, who's got PTSD and opioid use disorders, using fentanyl? Do you just go ahead, start up the buprenorphine 8/2 BID, or do you do a microdose induction over 7 days? Or do you say, that these are primary care doctors, so what do you want your primary care friend to do? Refer them to a chemical dependency treatment program, inpatient, or refer them to outpatient psychiatry because of the PTSD involvement. So what do you want? What would you do? Or if you want, you can also ask, what do you expect a primary care doctor to do in this setting? This question is designed to be advanced for a primary care doctor and to be a little tricky for the experts like you all. I kind of was torn. Okay, I love it. So you kind of fell into my trap. A lot of you wanted the micro induction. And there's a very specific learning point here, which I think is really interesting. When you go back to the case, I am describing what you need to do to calculate a COWS. It's a little unfair because it's not like anybody can just calculate a COWS without seeing the scorecard, but I'm giving you a COWS score. And the COWS score at which you can just start bupe is 8. And this person had like a 9 or a 10. So the key learning point here is we torture ourselves and we torture our patients with all these complex protocols. But if they have a COWS greater than 8, cut to the chase, just give them the meds, just start it up. And why do I say that? Well, I'll get to the reason behind that in a second, but I'll just start. I also just will, it's very interesting to me that opioid related deaths have plateaued. And they really hopped up during COVID, and now they're kind of plateaued. Why? We have a lot more Narcan out there. We have a lot more Suboxone or buprenorphine out there. Maybe because, this is my pet theory, people are switching from IV to smoked fentanyl. That's a real thing. because fentanyl is so potent, you don't need to inject it. You can just snort it now. So maybe they're switching away from IV, and that's why their deaths are going down. Maybe just a ton of people, unfortunately, died during COVID. All the high-risk users died during COVID. So maybe that's like regression to the mean. And maybe there's public education. That's, we're more aware about fentanyl in the drug supply, and people are using more smartly. Who knows? But we're at a plateau right now, so that's good. You don't need to be told buprenorphine is a good thing. The idea is no wrong door for buprenorphine. That's the hope, and the hope is that 100% of people who are using opioids, have opioid use disorder, 100% have access to buprenorphine or methadone. But methadone is harder to get. Buprenorphine can scale up better, but we want 100% to have access. And if we can get even 50% of people who have opioid use disorder on buprenorphine, we're going to call that success. So that's the big picture public health goal. The only way to get 50% of the opioid use disorder patients on bup is to make it a full system effort. No wrong door. You show up to your ophthalmologist. Your ophthalmologist maybe doesn't prescribe the bup, but can get it for you that day by referring you to a colleague. You go to the acute care, you go to your post-operative surgical visit, wherever you access the system, they can help you with this. And everybody understands it. So that's a heavy lift. So if we need to get at 50%, where are we at? I'll answer that question in a second, but this is, but this for this crowd, all DEA license holders can now prescribe bup, but all DEA license holders also have to do 8 hours. Probably not us, because you guys tune into Echo, so you got this locked down. The other thing that I was saying before we started, that I love is telemedicine, and telemedicine does have some pretty good data that it helps people stay in care and stay on buprenorphine and do better. So telemedicine is a good thing. All of our telemedicine exceptions have been extended until the December of this year, and I hope will become permanent. I think that the telemedicine exceptions for Adderall and Xanax and ketamine might go away. But I think the telemedicine exceptions for buprenorphines are going to stay. And right now that includes telephone only for buprenorphine, which I love, because I work with older people that don't do the telemedicine things. And like I was saying, telemedicine for opioid use disorder has improved outcomes, including less overdoses compared to in-person visits. So don't be afraid of telemedicine. I said, hey, let's get 50% of people on buprenorphine. So how are we doing with that? 18% of eligible people are enrolled in MOUD, methadone or buprenorphine. 18%, 15% get buprenorphine. 13% of the eligible people get buprenorphine. We are not doing well, and we're not doing well in anybody. But if you look at by race, white people have 20%. Again, the goal is 50%. So there's no great shakes for white people, but Black people are 15%, and Asian Pacific Islanders eligible people are 11%. And then if you look over here, who's getting hit with the overdoses disproportionately right now, Black and then Native American this is not the same category. These two top bars, I don't think those are the same categories, but it is worth noting that American Indians are hit really hard with overdose deaths. So yeah, nobody's doing well, but especially people of color are really not doing well. So we got to do better for them. And then also, do Black people have buprenorphine started after a medical event? They have a non-fatal overdose. They go to the emergency department. They get admitted to the hospital. They are known to have a medical problem from their opioid use disorder. And they are still started on buprenorphine 10% less than white people. But even white people it's like embarrassingly bad for even white people. So we got to do better for everyone. So buprenorphine, you understand what it is, so I won't belabor that. it's basically easy. I think we were complicating buprenorphine. This is a discussion point we can have. I think Kurt and myself and like addiction docs who love to talk about this, I won't name any names, but we know them. They're my friends. They're Kurt's friends. Love to geek out about the pharmacokinetics of buprenorphine. I think that's great for addiction doctor nerds to do on their own. But I don't think all this, what is the dissociation constant and the receptor occupancy percentages and the delta and the kappa and all these things, I think that's there for those who want all that level of detail. But I honestly think sometimes people's eyes glaze over and they're like, sounds complicated. Maybe it's not for a primary care doctor. If I have to remember what a delta opioid receptor does, nobody ever taught me that. If I have to think about all of these affinities and all these microinductions and all these things, all of the microinduction protocols. I mean, it's insane. So I think we overcomplicate it. And so here's my attempt to simplify it so that people, a busy primary care doctor can do it. Basically, it should be easy to do with one catch. Don't start full dose buprenorphine when someone is currently on opioids, because you'll get precipitated withdrawal. But if you start buprenorphine correctly, precipitated withdrawal should be less than 1%, right? So you should be able to do this so that this serious adverse event is very uncommon. And then if they do have precipitated withdrawal, what do? You give them high dose buprenorphine, but let's just like prevent it from happening. And these talks sometimes spend 30% of their time talking about low dose inductions. I'm going to spend 0 on low dose inductions because I don't think it's established what the right protocol is yet. Every month there's a new protocol. Everybody's got a protocol. And that means we don't really know what the right way is. And I think it's a little complex for primary care when they're not even doing a normal induction yet. So my goal for primary care is start with the traditional induction, learn who's eligible. There was, let me see. The reference is early, a few slides earlier, but there's a study from, I think it's D'Onofrio, I think it's Colorado, where she's looking at an emergency department patients with opioid withdrawal. And she has looked at more than 1,000 and started buprenorphine, normal dose. If their COWS is greater than 8, the risk of precipitated withdrawal is less than 1%. So I'm just like, let's just start there, because that's like an established, this is safe. You got to trust who's measuring the COWS, because not everybody's is comfortable with the COWS, but if you trust that they truly are in withdrawal based on the COWS score, just start with, make it simple. And all the microdoses, whatnot, that's for the experts maybe for now, unless you want to learn more. So the other question that I think is very interesting is, how is fentanyl different from other opioids? And this is another very big debate in the addiction community. On the one hand, there's fentanyl is like the big bad ugly. It's different. We need to do things differently. We need the most complex microinduction. We need X, Y, and Z. Fentanyl is just this complicated thing that is going to give us worse outcomes, and we just don't understand how to treat fentanyl users. And then the other end of the spectrum is fentanyl is just another opioid. We can handle it. We have the tools to do this. Yeah, there's some differences, but it's basically just another opioid. I started out in category 1, and I'm kind of migrating towards, I think we can do this. It is true that fentanyl users need a higher dose of buprenorphine. However, fentanyl users versus non-fentanyl users have a similar rate of retention and treatment and follow-up, which is very important, at least so far in the literature. And fentanyl users do indeed have a slightly higher risk of precipitated withdrawal, but it is still under 2% rather than under 1% if an induction is done properly. And naloxone still works. Fentanyl is not like immune to naloxone. So I think there are some adjustments we need to make to treat fentanyl users well, but it's mostly business as usual. And that's kind of my take. So I'm trying to simplify. The other thing that I wanted to point out, which is kind of an interesting horizon, and there's some actual data for it now from this year, interestingly, is that supervised consumption sites do lower death. And so supervised consumption sites are basically not legal in the United States. I think there are some cities, maybe New York City. It's been done for decades. In Switzerland, it's established that it lowers the risk of HIV and hepatitis C. And in this study in Canada, the presence of a supervised consumption site lowered death within a square mile of that site. Okay, so it's a little specific, but basically it lowered mortality by 2 per 100,000 people a year. And what does that mean? That's like a really weird number. Normally, opioid-related mortality is 32 per 100,000 people a year. So it's like taking 32 and turning it into 30. So in other words, maybe 8% reduction or 7% reduction in mortality. Okay, that's really good. So, I mean, I think if we could reduce mortality by 7%, so I'm not sure America's ready for this, but at least this interesting new study did show that supervised consumption sites will significantly, now it doesn't make deaths go away. It just reduces death by 7%. It's not as powerful as being on Suboxone, but it does help. And then there are a million more topics that are hot topics, that are fringe topics that we could talk about, and that are very important emerging topics, but we can't talk about everything. I do want to point out these two that I have an asterisk on in the lower left-hand corner. Methadone regulations have already been updated. They are different now, and they will likely change again soon. So methadone is going to become more available soon. And confidentiality laws have been changed. So HIPAA, so now addiction confidentiality is a lot closer to standard HIPAA. And so I put the references there. There's my wrap up. I got 2 more to talk about. I think I could maybe get done. Hopefully I'll move fast. This is good for me to get the timing down. Whew, I'm gonna have to move fast or maybe cut some stuff. Okay, which statement is most true about alcohol? Consuming any amount of alcohol worsens health. Healthy alcohol consumption is equal to less than 1 drink per day for women and 2 drinks per day for men. And drinking red wine is cardioprotective, or beer before liquor, never sicker. Liquor before beer, you are in the clear. Which one is true about alcohol? And I called this a poll because I don't want to cause a fight by, claiming that I'm right, because a lot of people have strong opinions about this stuff.
I'm wondering, Charlie, what small town you got D out of?
That's the small town of Madison, Wisconsin, the University of Wisconsin, where this is part of the curriculum at the University of Wisconsin. Yeah, I agree with everyone's answers, is that I would say A is the correct answer. And it's interesting that this is actually relatively new, that this has been accepted in the last couple of years. It is now generally accepted that there is no healthy dose of alcohol, that there's no such thing as a healthy dose of alcohol. And there's lots of data on all the ways that alcohol worsens health and, causes economic hardship because of health effects and cardiovascular effects. And the cardiovascular benefits of wine are probably overstated, et cetera, et cetera, et cetera. This is an interesting World Health Organization slide on drinks per day and relative risk of I think different types of diseases. The good news in this study is that if you reduce your alcohol consumption, you can, even while you're still drinking, you are still drinking, but you are just drinking less. You reduce your risk of liver disease, psychiatric disease, and cardiovascular disease. So you can just reduce your drinking and lower the unwanted medical outcomes. So that's good news. And instead of saying healthy alcohol use, what the World Health Organization says is low risk alcohol use. And I think saying 1 drink a day for women, 2 drinks a day for men is low risk alcohol use. I think that's fair. I think we cannot call it healthy, but it's low risk. So you all know this, but I still use this as an addiction doc. This is my favorite, probably of all my screening tools. This is the tool I use the most, which is how many times in the last year have you had 4 or more drinks in a day if you're a woman, 5 or more drinks in a day if you're a man. And if the answer is any number of times, you proceed to the next questions. On average, how many days a week do you drink? And on a typical day, how many drinks do you have? And then you know the average drinks per week. And if it's 7 or more drinks for women, that's positive, or 14 or more drinks per week per men, that's positive. And if you have a positive on both, you proceed to a diagnostic interview for alcohol. Primary care docs might want to use audit C next. That's a substitute. If you are no to the first criteria, your risk of alcohol use disorder is 1%. If you are yes to the first criteria but no to the second, your risk of AUD is 20%. And if you're yes to both criteria, your risk of AUD is 50%. And there is not really a validated screening tool for gender diverse individuals. So I usually use whatever gender they were assigned at birth, or like their anatomic gender, and not their actual gender. That's how screening tools, regardless of what you're screening for, usually uses one's anatomic gender. So now back to this beer before liquor, never sicker. There is a study on this topic, and the study was titled Grape or Grain, Never the Twain, which is another expression. You either drink wine or you drink beer. Don't mix your wine and your beer. That's what that means. So the question is, does mixing different types of alcohol in different orders worsen your hangovers? And the answer in this study is that no, neither the type of alcohol you drink or the order in which you consume it affects your hangover. So what does affect people's hangover? How drunk they get. It's not that complicated. If you get drunk, you'll pay for it tomorrow, and it doesn't matter how you get drunk. Okay, so someone who drinks is going to surgery. This is a preoperative case. 55-year-old woman presents for a pre-op for a knee replacement. Her medical history includes osteoarthritis, obesity, and alcohol use disorder. She drinks multiple mixed drinks per day, and she often skips meals. She becomes tremulous after just 24 hours of abstinence, and then she returns to alcohol use. She does not wish to enter treatment or quit alcohol, but she would be willing to cut back for her surgery. Blood pressure's a little high, heart rate's a little high, she's afebrile, her oxygen's okay. You can smell alcohol when you examine her. She's got a big abdomen, it's hard to know what that's about. Otherwise, her exam's normal. So what is your preoperative assessment for this person who drinks alcohol? Proceed with the surgery, cancel the surgery, initiate naltrexone for alcohol use disorder and proceed with the surgery, and check liver enzymes. This is, I think you all are going to not fall into the like trap that has like sirens and flashing lights on it. But hopefully not. One of these answers is like, whoa, don't do that. So I would not do C. I think you need to check her liver enzymes. Like if you go back and you're like, she's a 55-year-old woman who drinks mixed drinks all day and doesn't eat food, she's at risk for cirrhosis. And her abdomen is so distended, you can't really get a good exam. You don't know what this woman's liver is like. And so you really, before you do anything, and I'll talk about why. So if you're doing a pre-op assessment for patients with alcohol use, there is a new, and I think I talked about this on Echo in the fall. There is a huge change in recommendations, and it's on that first reference I put down below by a multi-organizational consensus for preoperative assessments, that we should be screening people for addictions pre-op before they go to surgery. If you're doing a pre-op on someone, you should ask them about addictions. And then if they have an addiction, you need to do further assessment and offer them treatment, ideally before the surgery. Sometimes surgeries are emergencies and they gotta go. So then if they have to go, they have to go. In addition to screening for alcoholism, a nutritional screen for the risk of alcohol withdrawal, and rule out cirrhosis, and we'll talk about the reason why. And audit C, separate from diagnosing alcoholism, also predicts postoperative complications such as infections, heart problems, bleeding. And here's the good thing about if you have a high audit C, and there's a reference down here to sort of understand how to do this, if you are at risk of complications, if you can lower your drinking 1 to 4 weeks before the surgery, you can improve your outcomes. I think I'm gonna go for a few more minutes. I might run out of time. So this is my favorite screening tool for severe alcohol withdrawal, and that's the PAUSE score. So if you're concerned about alcohol withdrawal, you can look at this screening tool to predict alcohol withdrawal. And in addition to that, preoperatively, if they have ever had alcohol withdrawal seizures, you need to document it and you need to have a plan for it. Otherwise, they could have a seizure in the PACU, the surgery recovery unit. So you don't want to send someone to surgery who has alcohol withdrawal seizures unless you have a plan for those seizures, because they're going to have a seizure on postoperative day 0. And these are other symptoms or signs of complicated alcohol withdrawal that you should make note of before they go to surgery. We are all about the naltrexone, but you cannot give naltrexone perioperatively. This week, we canceled a surgery in someone who was getting naltrexone for alcohol, and they had taken their last pill within 24 hours of their surgery, and it was a complicated surgery, and we just had to cancel the surgery. So the naltrexone is no-fly zone for surgery, unless it's I don't know, maybe a dental extraction, maybe. So, but naltrexone is evidence-based to lower return to drinking, to lower heavy drinking. Also, ecamprosate, evidence-based to lower return to drinking. Gabapentin outperforms benzos for mild alcohol withdrawal and lowers alcohol cravings, lowers alcohol drinking. IM naltrexone lowers alcohol use and improves quality of life, and decreases, and all these decrease progression of liver disease in patients with alcoholism. And everyone with alcoholism should get thiamine and a pneumonia vaccine. So there's a lot we can do for these folks, and we're just not doing any of it. Let me just leave it at that. So, and how well are we doing initiating medications at the time of hospital discharge? Literally, people with alcoholism are given medications for their alcoholism 1.3% of the time. And yet the number needed to treat is 12. So, I mean, we talk about 13% was the number that Suboxone was prescribed, and 1/10 as well. 1.3% of people with alcoholism are given medications, and surprise to no one, non-white patients do, but white patients are getting 1.3% of the time. So we are really stinky at treating alcohol withdrawal. So, and I'm just to move quickly, I'm just gonna sort of, instead of, you guys are probably a very educated crew on methamphetamines and all the challenges of methamphetamines. Here's a study on mirtazapine for methamphetamine use. Kurt, if you've never had Phil Coffin from San Francisco talk, he's a great speaker on this. But I'm just going to say we need to be doing a lot for the methamphetamine users. And here's a list of the kinds of things to think about. Statins, prophylactically, because meth users get so many heart attacks and strokes. Housing, financial assistance, syringe programs, fentanyl and xylazine test strips. Pre-exposure prophylaxis. I had a patient accept PrEP for HIV who's an IV meth user recently. It was like so cool. We are diagnosing syphilis once a week. So you got to check an RPR. Hep C, contraception, wound management for people who are exposed to xylazine, especially psychiatric services. And the medications are mirtazapine, bupropion, and naltrexone. And I will stop there because I want to have time to answer questions. So I skipped over meth. I got to work on my flow, but I am curious. We've got some questions in the chat. Do you want me to read the chat, or does someone want to read them for me?
Yeah, either way, you know, there's actually quite a few questions at the beginning. You know, it's interesting too, Charlie, you bring up the low dose and the high dose inductions. And I do think the one difference with fentanyl is often they come in and they use so frequently, it's hard to find a gap in their use to slip it in, which was different than heroin, right?
Yeah, I mean, it is true that it's hard to find. I mean, what I do is, I mean, I will do microinductions, low dose inductions for sure. But I also ask them, how many times have you had withdrawal? And they're like, oh, it's not like they've never had withdrawal. It's just that they're not in withdrawal right now. And so then I could say, well, the next time you have withdrawal, you could just start this right away, or you could do a low dose induction. But my point is the whole like strike while the iron's hot. If someone's in front of you and they're ready, you should do it. Do it simple. Do it the old school way. And that, especially in hospitals, people are more likely to see that when they come into the emergency room. They're in a controlled setting, they go into withdrawal, and then you can start it. But you're right. You're right that it's sometimes you just don't see these folks. It's hard for them to get into withdrawal.
Yeah, and to be honest with you, I very frequently, so that they feel like I've done something, I will start with 0.5, even if they're not, just to make them feel like we're doing it, we're starting, and then spread it out and get them going.
Yeah, I think you're right. It's sort of like interesting. I made a choice to focus on this. Cows of 8 is the cutoff point, which I think is like a helpful fact to remember. But how often do you see people over at cows of 8 is the question. Okay, what else?
All right. Do you want to do some of those, Aaron, some of those questions that are in there?
Sure. And I think it was a great reminder in that section, make sure your staff are adequately trained on cows scoring, because that could really mess your day up.
Oh,
yeah.
I mean, down in the methadone clinic, I don't trust my counselors' cow scoring. Oops, they may be on. I gave them a link to this. Hi, friends. Every counselor scores it differently. And there are people who are like, they have a cows of 15 and they're falling asleep. And so I am always careful how I interpret a cow score.
Yeah, there was a question by Abby about how long you recommend abstaining from cannabis pre-op.
So I used to just like BS on this because I figured nobody had an official opinion. But I think there's now an official recommendation. I think it's 1 week. I think there should be references in a slide that refer to that. There was recently like some official perioperative cannabis recommendation guideline. I think that was 2022. And I think they said 1 week, but it was not a day. It was significantly longer than a day. I think most of the cardiovascular effects that are modifiable, 1 day is enough. But then they're going to go into cannabis withdrawal, because cannabis withdrawal is like 2, 3, 4 days, 5 days. And so I think the 1 week gets them fully clear of all the cannabis withdrawal and they're like ready to go. They might be a little cranky, but they're ready to go.
It's so scary. I was an OR nurse for a long time, and like in their pre-op H&P, substance use was not addressed. And we were never addressing that when we were getting ready to take them back for the procedure. You'd listen to the CRNA, they were never asking those questions. So surprise, that could easily happen. It's scary.
And then they react weirdly to anesthesia, or they're in withdrawal, or they have some they come out of surgery and they have some kind of you're like, what's going on with this person? But yeah, I mean, we are so dialed in on cardiovascular risk pre-op, potassium and EKG and
Yes.
their beta blockers and the whole 9 yards. But we don't even ask them if they have an addiction. And so hopefully this recommendation will increase that. But then a lot of people are going to be like, but what do we do about it? So
One of
The
the things when you
acute seizure thing, holy moly. Sorry, Kurt.
no, that's okay. I was just gonna say, Charlie, with the marijuana risk, cardiac risk, how about if you add cocaine to that? I mean, that would be kind of an interesting combo.
yeah.
For heart attack, really, especially in the older.
I haven't seen great numbers so I think all these patients are really hard to study, but I think the cocaine methamphetamine users are really tough to study. Our friend, Dr. Specker, has tried to do this, and it's hard to recruit and retain study participants who have stimulant use disorder. That's kind of the nature of the beast, unfortunately. Gavin's doing a lot of stimulant use disorder, so I don't know what his retention's like. I have not seen really good numbers on cocaine and cardiovascular risk, but it's got to be, I would guess it's closer to tobacco than it is to cannabis. I would guess cocaine's significant.
So our friend Ashley asked, what do you consider heavy cannabis use? My thought would be, have you watched Cheech and Chong? I don't know the movie. Never mind. But do you have a thought of what's considered heavy?
Dude, have I watched Cheech and Chong, the movie? They have 10 movies, and each movie is the same. They're driving around, getting stoned, acting like idiots. And Chong one of them had their house raided.
Yeah.
Because he was trafficking interstate cannabis products, I think was you could just, the visual is some guy sitting on his couch, stoned, hanging out, and they kicked down his door and ran in with guns. And I think he even gave an interview where he was like, okay, I sent cannabis to Pennsylvania. My bad. But you don't need to bring machine guns into my house. It's just that's hilarious. I think it's daily use. I think it's daily use, monthly use, and then and then annual use are usually what I see daily. So if daily use is considered heavy, I think, and even it's not even that heavy compared to, but I haven't heard of people going past daily use, like how many milligrams and doing an assessment for tolerance. I haven't heard of that.
Do you have a standard how long you have people stop the naltrexone pre-op?
Well, we just got into a big debate in my division, and we went round and round on it, and people got a little fired up, I thought, considering that we're talking about naltrexone. We all agree the person who took naltrexone within a day shouldn't go to surgery, but then we bickered for 10 texts about what the standard answer is 72 hours. And we had some in our division who says 72 hours for oral naltrexone on either end. That's the answer. And then so you have to stop it, wait 72 hours, get the surgery, and then stop opioids, wait 72 hours, and resume the naltrexone. I think clinically 48 hours is probably fine. Not that I'm going to gamble. I'm not going to gamble sending someone to surgery, but I think 48 hours is probably fine. But we're always going to say 72 hours because why risk it?
Someone asked if you'd be willing to come back and do a part 2 and talk about the slides that you skipped over, Charlie.
Yes, for sure. It's only a few slides, but I could find other things to talk about. I'm sure I do have a new pain talk in my head that I'm finishing now, so I could, and that won't be that long, so I could finish the slides and do the paint talk. That'd be cool. I'm gonna have the paint talk should be done by next week. So
Charlie, somebody commented that Tommy Chung is Canadian, so there might be other issues there as well. So I think we have to consider that. I
Got
have
it.
one other question for you, because I know we're kind of running over, but yeah, I'm just wondering if you're seeing some of this stuff where people go through the induction really well, but they are really irritable. And my concern has been, it's been xylazine withdrawal. And of course, we don't have the test strips. Have you seen much of that? I've especially seen it the last couple of weeks, months.
By the way, I have test strips, and I know that Alicia with Steve Rumler has test strips. So I hope she doesn't hate me for saying this, but reach out to her.
Okay.
I mean, I got test strips from her, and so they're legal, and so and we are giving them out. I mean, I'm giving them out.
How often are they positive when you check them?
I mean, I don't check them ever myself, but and we're gonna have a poster at ASAM looking at fentanyl test strips and reduced opioid overdoses and reduced readmissions to the emergency room when we give out fentanyl test strips. And so, but that's fentanyl. We haven't studied xylazine yet. I don't know how much is out there. Like, we talk about it a lot, but it has not at Hennepin blown up huge the way levamisole did a couple of years ago, where every cocaine sample had levamisole in it, or more than half of them did. It hasn't blown up like that. It's there, it happens, but we honestly haven't seen a ton of those big nasty ulcers, and we've seen them, but it's not huge yet, I don't think.
Okay.
So,
Any other questions, Aaron, that you saw that I didn't? Okay.
all right.
Well,
Thank
we
you so
will-
much.
Yeah,
Really
we will have to
That was
think about,
awesome.
yeah, we'll have to think about having you back to do the math part, because that's interesting. I saw your slides going
Cool.
by, so.
Cool.
So
Yeah.
thanks
Thanks, everyone.
again, Charlie. Thanks everybody for coming. See everybody next week for Miss LePage.